I'd like to introduce our second speaker. Marc Larrivée is with MOSAIC, a member of the Vulnerable Immigrant Populations Program, or the VIPP Alliance. Marc is the Senior Manager for Specialized Programs at MOSAIC. He oversees a cluster of programs which serve MOSAIC's most vulnerable clients, including convention refugees, victims of domestic violence, and crime. For almost 20 years, his work has been dedicated to services to newcomers in both Canada and the United States. He has also done research in both countries on promising settlement practices. So welcome, Marc.
Good morning, everybody. So, I'm going to go through this step by step. I should first say, I remember there used to be this commercial on television back when I was a kid, and it was somebody who came out and he said, I'm not a doctor, but I play one on television. Well, I'm not a psychologist, but I talk about mental health on the internet. So I'm just going to go through some of the learnings that that have come to us over the years and that I've worked on, and some of the work that we're actually doing at MOSAIC right now. I'll go through this one by one here. So talking about, we're trying to respond to the mental health needs of newcomer populations, and we've been doing this in a variety of different ways. But before I talk about that specifically, I just want to set some context about mental health. Now, people talk about mental health, and I think that for newcomers sometimes it can be confusing. People may not even understand that terminology. And so I did put up a definition here that the World Health Organization has for mental health. Now, this is a positive definition of mental health, talking about mental health as actually a resource. And you can counterpose that, obviously, with mental illness. Mental illness is not, let me put it this way. Mental health is not only the absence of mental illness. Actually, it's a resource that people can draw upon to actually fill their goals and their needs in their life. As opposed to mental illness, which is when somebody's mental health is actually disordered. And I think that the people here in this room, a lot of people, online right now, can relate to this in terms of talking about the different disorders that they see in their clients, be it depression, anxiety, and then even major mental health disorders such as schizophrenia, bipolar disorder, and such. So I think it's important to look at mental health on a continuum. If you look at this slide here, it talks about somebody who is actually healthy, right? Now, if somebody is quote-unquote healthy, it doesn't mean they're not dealing with stress. It doesn't mean they might be having distress at times. But it may mean they may not actually have an actual impairment as such. And then you move on in the continuum here, and you have people who might have some mild symptoms of mental illness. And then obviously somebody who has major mental illness is towards the other end of the spectrum. It's estimated that 6% of the Canadian population will experience a mental illness in their lifetime, so that's 6 million people. And this cuts across all different populations, no matter one's age, education, income level, or their cultural background. So in terms of immigrant and refugee mental health in particular, often people talk about immigrant and refugee mental health, and there's this kind of elision that takes place. People put those two words together, and obviously these cohorts are quite different, right? Immigrants and refugees have different mental health experiences. It shouldn't surprise people, but I think often what happens when we have these discussions, sometimes they get grouped together. And that does a disservice, to the actual experience of the different populations we're talking about. So the research obviously confirms this. Now, when immigrants come to Canada, actually they have a slightly lower level of mental health disorders than does the general population in Canada. What happens over time is that as some people are here longer, you know, if someone's here after about 5 years on average, that the rate actually the rate of mental illness or mental health disorders is at the same as the Canadian population amongst immigrant populations. And of course, refugees and immigrants, I'm talking about non-refugees here. Also, it's indicated that if youth are coming to Canada, I don't know if I've switched over to the next slide, excuse me here. Okay. Yeah, so sorry about that. So youth that come to Canada under the age of 12, their rates of mental health disorder or mental illness is at the same as the Canadian population. So moving on here. Now, in terms of refugee populations, right, it shows that refugees are much more likely to experience mental health disorders than immigrants or the general population. One study has indicated that they're 10 times more likely to have PTSD than Canadian-born population. Likewise, they have a comparatively higher rate of depression than the general population. We can look at what some of those reasons are. Now, often in the literature, and there's somebody who's done so much work in this area, his name is Lawrence Kermeyer at McGill University, and this is information from the Canadian Collaboration for Immigrant and Refugee Health. And often looking at immigrant and refugee mental health, and these are combined here, because these factors relate to both populations, but in different ways. So we can look at, I think that in your folder there's information about this, right? There's pre-migration factors, migration factors, and post-migration factors. Some of these affect, as I said, immigrants and refugees differently. Some of them affect mainly only refugees, and some of them affect both populations. So if you look at these, obviously pre-migration factors, trauma, civil war, torture, threats to security, these are factors, obviously, that are affecting refugees. Now, of course, there are times that immigrants arrive in Canada who've had a refugee experience, but they end up coming as immigrants, so we can't discount that. In terms of looking at these factors, what the research indicates is it's really a best practice to look at these factors when working with populations, depending on the service you're providing. Of course, if somebody is coming to you for an employment service, you're not going to collect information about what their pre-migration look like. But if there are services in the community, obviously, and you find that there's a need, you're going to do that referral. But if you're doing settlement work, and if you're doing work specifically with vulnerable populations, I'm thinking about the program that serves government-assisted refugees that I oversee at MOSAIC called the Moving Ahead program. This is one of the things that we make sure we do. We collect information about people's history, how they came here, what they're experiencing before, what their journey looked like, and then, of course, obviously, we're working with them and what's happening for them at that time. In terms of what might be a factor that's affecting someone's mental health, as an immigrant, loss of status is a big piece of the pie, right? Somebody may have been a professional in their country, and now they're actually just working a survival job, and this obviously is going to have an effect on their mental health. So, looking at this here in terms of mental health services or, Western mental health practices, right? Do immigrants and refugees actually access, the type of services that are out there? And actually, specialized services for these groups, there's not much out there, frankly, right? I mean, it's great to have VAST, but some of the services that have existed in the past actually have been reduced in recent years, unfortunately. But nevertheless, why is it that immigrants and refugees don't necessarily access services? And this information I have in this slide comes from the national research. It's actually a compilation of lots of different studies that were done, and so this is pretty well validated on what are some of the reasons why newcomers don't access these services. Clearly, and this is a pretty obvious one, lack of linguistic accessibility to services, fear of stigmatization. I think that we talk about stigma as it relates to these populations. Of course, stigma is huge in mainstream Canadian society as well. So we can't, you know, I think that there's sometimes this idea, well, immigrants don't, you know, there's too much stigma and it's a cultural issue for them. Well, stigma cuts across all cultures. So that's actually creating another stigma in a sense if you just say, okay, you know, newcomers are not accessing these services because in their culture they have, you know, they have an aversion to thinking about mental health. A sense that one can solve their problems on their own. Of lack of knowledge about services. People just don't know what there is out there. A belief, and this may become from people's country of origin, a belief that seeking out services is for the severely mentally ill. It may be in someone's country of origin, people who are designated as mentally ill or those people who are actually hospitalized, because that may be the only service that may be available in their country of origin. And also there's a lack of culturally appropriate services. Okay, so these are the main reasons why that we found that newcomers are not necessarily accessing services. Okay, and this does, I think, I'm just looking at my note here, it does really mirror what we've seen locally. So what we've tried to do at MOSAIC, you know, at MOSAIC, we've really wanted to respond, you know, to this issue and to the lack of services. And we were able to access some funding through the City of Vancouver back a couple of years ago through their Innovation Fund to collect data about, you know, what are the cultural practices that might actually enhance the mental health within different ethnocultural communities. And also, what are the barriers? You know, we want to ask people in the communities themselves, what are the barriers? Why are they not accessing services? So we did this by doing focus groups. It was some qualitative research. And the first step was we talked to different professionals who, you know, focus on this issue, on immigrant and refugee mental health. So to develop how we're going to go about that research. And based on that consultation, we put together focus groups and developed some questions and figured out how we're going to structure the sessions. Like I said, this was funded by the City of Vancouver, and so we focused on the largest ethnocultural communities in the city. We thought that made sense. And so the focus groups were the Chinese community, the Filipino community, and South Asian community. And just to go back in terms of also, I didn't mention that we talked to professionals before we started the actual research to get their input and guidance. We also talked to what we call cultural informants. We talked to people, mainly it was settlement workers at MOSAIC, from these different ethnocultural communities to get their insights in terms of how we should approach doing this work. Okay, so the main topics we addressed were the accessibility of local mental health services, and I put the scare quotes around accessibility because it's not just actual access in a very kind of definitional kind of way. And the next slide will elaborate on that more. Specific cultural healing practices, we wanted to find out, okay, if somebody is dealing with what we would call a mental health issue, what do people do in your culture to actually support that person? And also just wanted to find out what you think will help, So this is what asking, the focus group members about suggestions for future programming. Okay, so this is, hopefully, yeah, I think that's large enough for people to see. So this is pretty much what we found. Okay, we have these different categories here. I already mentioned stigma earlier. As the national or literature shows, we also found the same thing in the research that we did. Feeling as though it's not only a question of stigma from their community, it's also a question of people feeling as though that they're going to be labeled if they see a psychologist, and that there is no kind of continuum. Either you're well-functioning, or you're crazy. So this is a major feature that people describe to us. And then there's also people's different cultural understandings of mental health. And what I'm getting to here is that we look at this in terms of how people don't look at mental health as one aspect, of their well-being. It's integrated with their spiritual health, their mind, body, their mind, body, and spirit. And so mental health is not necessarily something that's looked at divorced from the rest, kind of more in a holistic way. And so actually going out and trying to access something specifically, just mental health, I'm talking about there are many immigrants in these focus groups. I'll limit it to the focus groups, would say, well, in our culture, the idea that you would go and sit with somebody and talk to them for an hour about their problems is kind of foreign to us. We don't know how that will help the fact that I don't have a job and that my family is, doesn't have food in the fridge, whatever it might be. And so maybe there are other ways, that I can help myself. Other ways within my own cultural community that we have determined that will enhance my well-being. So, other pieces here that often that mental health problems manifest themselves in bodily issues, right? And so people will go see the doctor a great deal. Or there's actually a cultural understanding, about a physical symptom. Okay, I am out of balance right now because I'm having this physical symptom. And we may look at that in this culture as a mental health disorder. So it has to do with how do we kind of bring those two pieces together. People's own cultural understanding from their community with our understanding of how we provide mental health services here. Obviously, there are environmental stressors that keep people from seeking out help. If people are looking for a job, if people don't understand the language, if people are experiencing discrimination, and many other factors here. Practical barriers, obviously, if people lack awareness of the services, this is going to keep people from accessing services. I'm going to move on here. So here's some of the healing practices that people talked about. And for those people in the focus groups who indicated that, okay, well, they have recognized what they're going through. And some people in the focus groups, had themselves personally kind of struggled with their mental health. Others may have had family members who had. And for those people who say, okay, this is a mental health issue, I do understand it as such, often what they would do, they would isolate, right? And they would use self-help. They would read books. They would read books, and books may tell them, okay, I need to get more exercise, I need to socialize more. So people actually, they did things. They would talk to their friends and family members, and then, of course, as a last resort, people would talk to their doctor and may get a reference to a psychiatrist. Other ways that people would deal with perceived mental health problem would be just utilizing what they've known from their own culture. And people talked about acupuncture. People talked about traditional Chinese medicine as a way of dealing with their distress. And then a large part from the communities, obviously, were faith organizations, going to church, going to temple. looking for a spiritual healer to help them, and involving themselves in different rituals that may actually provide some help for their distress. One note here I made was in terms of actually people accessing, you know, spiritual healers, or talking to a minister, or talking to 5 more minutes, okay, talking to somebody directly and feeling as though, I think people saying if their learning is that their connection to God, you know, is somehow harmed in some way, their connection to God is not good, and that's the reason why they're under distress. That can be helpful, you know, in terms of people feeling as though they can make that connection stronger. But other people feel also that's problematic for them as well, because then the focus is on them and they're failing to have a strong connection, right, to their higher power, whatever that might be. Okay, so I'm going to speed up here a little bit. In terms of suggestions that people had, destigmatization was a major one. Just saying that within their different communities, within the Filipino, you know, South Asian and Chinese communities, we need to, you know, destigmatize mental health, just normalize it, you know, as my colleagues here were talking about. I mean, if people are going through traumatic experiences, going through major life changes, it's normal maybe to be dealing, you know, having stress in your life and dealing with a mental health issue. So just kind of destigmatizing it. Next thing is psychoeducational programs, just a better understanding about mental health within different communities in general, because there was a group of people who pointed out that family members, you know, sometimes get anxious when they have another family member, say, you know, there's a brother or sister who's really struggling with their mental health and they're depressed, and mom and dad and the rest of the family, then they start to get more anxious because they don't have a good understanding. They may start to fear, and this is what people said, you know, suicide, when maybe there's really no suicidal risk at all. But they, you know, immediately it gets catastrophized because people don't have the knowledge, you know, about mental health. People talked about therapeutic group activities, being involved in activities that can help them, that isn't necessarily talk therapy, structured outings in the community with a counselor present to be able to talk about their problems in kind of a casual way. That was one piece. People also talked about making sure that counseling services or services in general are in the community, either, you know, maybe a community center, people said, or a settlement agency, essentially because because in their perspective, mental health services are often focused in hospital settings, and then that's where the stigma comes in, the stigma of, you know, major mental illness, institutionalization, and such. People also talked about the importance of linking with religious organizations to actually get out the information. It's a way of educating different communities. Obviously, faith-based organizations in the immigrant communities are central to their lives. And that being the case, sharing information about mental health with them to disseminate it, and also it helps with destigmatization. People also pointed out, too, they felt that often mental health is addressed with their family doctor, or with, you know, lots of immigrants and refugees end up going to walk-in clinics. And the people who in the focus groups we talked to really felt like, you know, doctors, they don't really talk about this with them. And there may almost be an aversion to it. Maybe because they think, well, maybe this person doesn't understand mental health, and so they just don't get into it. So they felt if people go in with physical complaints that might actually be underlying mental health problem, that doctors should actually perceive that and give appropriate referrals. Okay. So some of the other information that academic research shows is that it talks about the importance of culture in both diagnosis and treatment. that you need to take it into account. The need to employ multiple sources of helping, including traditional forms of healing, are important. And counselors, psychologists, and psychiatrists should work in collaboration with community-based organizations like immigrant serving organizations. I'm speeding up here because I'm limited on time. A couple things I'll just point out how MOSAIC has been working with a clinical consultant. Now, I mentioned the Moving Ahead program earlier that provides long-term case management for government-assisted refugees. And then I also oversee the programs on domestic violence and also victims of crime and other programs as well. And we have a clinical consultant who talks to staff. And the purpose of the consultant, of course, is not to diagnose or to see clients, but what it is to help the frontline staff in terms of helping those clients towards their goals. Some of those clients may be identified, may be struggling with anxiety, or depression, or family issues. And what this person is able to do is help them in terms of how they meet those goals given what they're going through. And just the one last thing I'm very quickly going to say, because I think I'm just about to get the hook, is that recently, this month, we started a new counseling program at MOSAIC, multicultural clinical counseling program. And we're working with Adler University. We have students now. And right now, it's not really open to the general public. It's internal. We're taking internal referrals. We have a PhD student and a master's level student who are going to be doing counseling. And we'll be on a sliding scale. We're going to try to keep the fees as low as we possibly can. So, thank you very much.